Hello everybody. Today we are going to discuss about the traumatic brain injury and ARDS. In traumatic brain injury patient, the primary aim of the ICU management is to minimize the risk of secondary brain injury. In this context, the management of the raised ICP is paramount. Many ICP lowering treatment have been proposed, and the current clinical guideline and algorithm suggest applying these strategies in the stepwise fashion, starting with the less aggressive and safer treatment and reserving the more aggressive one for the refractory cases of intracranial hypertension. The most recent, Seattle Consensus established the 18 intervention group into tier 1, 2, 3. The basic zero-tier treatment consists only in the main tenets of homeostasis, that is, avoidance of fever, analgesia, sedation, intubation, and mechanical ventilation, targeting normoxia and normocapnia. If ICP increases, the use of tier 1 strategies is suggested. These include maintenance of cerebral perfusion pressure of 60 to 70 mmHg, deeper analgesia and sedation to lower ICP, osmotic therapy, targeted PaCO2 to 35 to 38 mmHg, and anti-seizure prophylaxis. In patients with persistently increased ICP, tier 2 treatment such as lower target of PaCO2 to 32 to 35, neuromuscular blockage, and the higher mean arterial pressure to increase CPP can be adopted. Finally, in case of refractory intracranial hypertension, the most aggressive and the high risk of complication, tier 3 therapy, that is barbiturate, hypothermia, and decompressive craniotomy could be taken into consideration. Similarly, ARDS management relies on the stepwise approach with more aggressive strategies reserved for patients with more severe and refractory conditions. The consensus of experts provided 15 recommendations and therapeutic algorithm for managing ARDS, recommending the use of low tidal volume plateau pressure limitation, PEEP of more than 5 as an initial management. In case of persistent hypoxemia and according to severity of ARDS, guidelines suggest trying higher level of PEEP and eventually neuromuscular blockage, prone position, and other rescue therapy. Finally, the consideration should be given to VBA. However, when managing traumatic brain injury patient with ARDS, climbing one step of the ARDS treatment staircase can lead to worsening of ICP and vice versa. So in traumatic brain injury patient has no ARDS, the physician should follow the Seattle consensus, apply the different tiers of ICP measurement and consider the basic respiratory target, setting the recommendation by current guide, that is tidal volume of 6 to 8 ml of predicted body weight, PEEP of 5 and PEEP flat of less than 30, respiratory rate of 16 to 22 breaths per minute. On the other hand, patient with ARDS and TBI without intracranial hypertension with stable ICP despite lung protective ventilation setting, the latter should be continued with while strictly monitoring cerebrovascular function, preferably using multimodal neuromonitoring approach. In the case of mild ARDS with partial pressure of oxygen and the fraction of inspired O2, that is PaO2 FiO2 between 200 to 300 mmHg, tidal volume can be adapted and the increase provided driving pressure is less than 14 to 15 centimeter of water, and respiratory rate can be adapted if hypercapnia is not controlled according to the clinical picture. If ICP remains elevated, that is tier 2 or neuromuscular blocker can be considered. Similarly, if ICP remains unstable, protective ventilation target cannot be achieved, or respiratory function deteriorates, that is, PO2 FiO2 become 100 to 200. Prone positioning should be trialed with close monitoring of ICP or ECMO if ICP cannot be controlled. In addition to ventilatory setting and eventually prone position, decompressive craniotomy, barbiturate and hypothermia should be taken into consideration even in the stage of tier 2 of CETL guideline, if this can allow to more easily reach ventilatory target and lung protective strategies set. In case of severe ARDS, where PF less than 100, more advanced treatment tier ARDS and TBI staircases should we discuss. In this situation, VV ECMO support to optimize arterial blood gases and minimize the intensity of mechanical ventilation could be used more frequently in patient at risk of cerebral bleeding, while prone positioning can be tried at any time, taking in account multimodal neuromonitoring and minimizing the risk of increased IC. Finally, fluid administration should be dictated by clinical requirement, but generally aiming for conservative fluid balance. If cerebral perfusion pressure need to be increased in patient with traumatic brain injury, vasopressor should be considered in the first instance to avoid the fluid over. Despite the absence of strong evidence on the beneficial effect of the lung protective strategies in traumatic brain injury, we believe that recent studies and the result obtained in the general ICU ARDS patient would justify the rationale on using these strategies even in this population, if particularly if ICP is well controlled. However, if ICP is unstable, the best management strategy remains debated. In fact, in this case, ICP should be aggressively treated with intracranial hypertension, as intracranial hypertension is associated with worse outcome. But at the same time, the strategies to minimize lung injury and ventilator-induced lung injury should be adopted. So, pragmatic approach for the management of concomitant ARDS and traumatic brain injury. The representation of severity of the brain injury and intracranial pressure treatment is shown according to therapy intensity level. According to the CETL consequences, which defines the aggressiveness of clinical management to control IC. The higher the tire, higher the level of treatment required to maintain an ICP of less than 22. Aggressive strategy used to control ICP, that is barbiturate hypothermia, decompressive craniotomy, are highlighted in the picture only when used differently from CETL consensus, which allocate them to tier 3. As first instance, the patient have no ARDS, that is partial pressure of oxygen PaO2 FiO2 of more than 300. Basal ventilatory setting should be applied, including tidal volume of 8 ml of predicted body weight, provided plateau pressure and the low moderate PEEP. In this scenario, traumatic brain injury should be managed following three tier of CETL consensus. Mild ARDS, in this scenario, the clinician should first instance optimize the ventilatory setting, in particular increasing PEEP to improve oxygenation and increase tidal volume and respiratory rate in order to achieve partial pressure of carbon dioxide target required in the different tiers of CETL. If necessary, neuromuscular block agent can be used in this phase as suggested as tier 2 strategy for ICP control. Hypothermia, barbiturate, decompressive craniotomy should still be taken in consideration in case of refractory intracranial hypertension. In case of moderate ARDS, in addition to previous strategies, neuromuscular block can be used even in the tier 1 stage to optimize ventilation. Prone positioning can be applied, especially if the patient is in tier 1 and tier 2 stage of CETL guideline, but caution should be used in case of refractory intracranial hypertension. If these strategies do not allow to achieve acceptable oxygenation in PaCO2, more aggressive treatment can be taken into consideration. For instance, ECMO can be discussed in cases of severe intracranial hypertension, or on the other hand, decompressive craniotomy, barbiturate and hypothermia can be anticipated already at the stage of tier 2 treatment of IC. Finally, inhaled pulmonary vasodilator can be taken in consideration regardless ICP as temporary measure. In the case of severe ARDS, in addition to above mentioned strategy, ECMO and prone positioning can be taken into account at any stage of time. Thank you guys.